Hi, this is Laura Lyons, and I want to welcome you to Module 3 of the SonoMed Airwave Clinical Training for the NICU. We're going to be talking today about patient monitoring. And we'll go over the information that's displayed and how it can help you. We're going to talk about listening to the breath sounds, the alarms, and the maintenance and care of the monitor. In previous modules, we've talked about the three important pieces of information that you have. One is the diameter around the tip of the tube. One is any obstructions in the tube, and then tip movement. So movement of the endotracheal tube at the tip and not at the lip. And again, this is continuous in real time. You'll see it just as it's happening all the time. And it's information that's very easy to read and understand. Go to what we call our home screen. And this is normally what you would see if nothing is going on, right? On the left, I have an icon that's going to show me movement at the tip of the tube. And right now that is telling me that the tip of the tube has not moved at all from where we set baseline. We learned how to set baseline in Module 2. This information here with the yellow circle is telling me the diameter of the trachea right around the tip of the tube. So I have a trachea that's a 4.9 millimeter diameter. So why is passageway important? And essentially, if you look at the screen, again, on the left, I've got the normal, and on the right, I have what's a small passageway. You see on the right, I actually started out with a 5.3. That was my baseline. And now I'm in a 3.7 millimeter trachea. I've only moved down 0.2 of a centimeter or 2 millimeters. So it's showing me it's a small passageway. And how can that help you, and what could cause this kind of a small passageway? Likely this is just some swelling around the tip of the tube, or maybe even secretions right around the tip of the tube. If you had more movement on your left indicator, then it may have migrated into the bronchus, okay? Or again, you could have some swelling, as we said. We've even seen dynamic airway collapse, tracheomalacia. And this is also where you'd see if you had an esophageal intubation, if you were using this device to intubate. So seeing that small passageway or a small diameter around the tip of the tube can help us to determine a little bit more about what's going on with our baby and come up with some information that we didn't have previously. Now let's talk again about obstruction. So this is what the screen looks like. Again, on the left is normal. And on the right, you see an obstructed endotracheal tube. You have an obstruction that is 35%. And you also see that it is right at about the 8 centimeter mark on your endotracheal tube, which means that I have a 35% obstruction in the middle of my endotracheal tube. Now, in this case, the alarm is going off, telling me that there's an obstruction detected. You can set that alarm to alarm wherever you would like it to, but you'll begin to see an obstruction at 20%. And how can that help you to know about obstructions? Again, knowing where you have the obstruction really helps you to know, to have better secretion management and know where you need to suction. Also helps you to know if you've removed the secretions. Let's say you had an obstruction or occlusion that was higher up in the tube. It might just be a kink. But in this case, it's down at about the 8 centimeter mark, and most likely in this case would be secretions in the tube. Knowing there are obstructions in the tube, knowing that secretions are building up in the tube can really help us to manage the secretions better in the baby. Now, one question that will often come up when people first begin to use the SonoMed Airwave is, well, does that mean if I see an obstruction, I have to suction every time? And the simple answer to that is no. Just because there's an obstruction in the tube doesn't mean you have to go in and chase that. That's really up to your clinical decision, right? However, if we wait until after the baby's desaturated to suction them, then we've allowed them to become desaturated. If we can learn our baby and know our baby well enough, that We know when there's an obstruction at what percent that baby's going to start desaturating. Then we actually can remove the secretions prior to desaturation. We're going to remove the secretions prior to there being a problem with worker breathing due to airway resistance even. Because as we know, when we have secretions in the tube, our resistance builds up. And then you can use this information to make sure that you really have cleared any occlusions in the tube. And once you've suctioned and suctioned properly, you also can listen to the microphones. And with those microphones, you can make sure that you don't hear any secretions right below the tube either. Because the microphones you can easily hear if there's secretions still in the tube or right around the bottom of the tube. You're going to suction straight through the SonarMed airwave. And so you're going to want to make sure that you're using the right length of a suction catheter and make sure that you know where to match up your lines on your suction catheter with the lines on the endotracheal tube. If you're using a 3.5 endotracheal tube, you will need to trim the tube just a little bit if you're using a regular length suction catheter in order to get to the very bottom of the tube. And we can talk more about that in person or show you this chart because I know you can't really read it on this screen. Now let's talk about endotracheal tip movement. And again, we're looking at movement at the tip of the tube, not at the lip. We can easily see movement at the lip, but there's often movement at the tip even if there's been no movement at the lip. On the left, you see normal. Again, I have 0, 0. No, it's not often at 0, 0 because we're showing millimeters of movement. And even just with normal breathing and slight movement of the baby, you're going to see changes in that number. On the right, at the top, I show the arrow that's pointing up, illuminated in green, and it says 0.6. That means that the tip of the tube has moved up 6 millimeters, or 0.6 of a centimeter, up towards the the cords. On the bottom, I'm showing 6 millimeters of movement down toward the carina. So that's movement upward and movement downward. And movement happens a lot. You're going to see that as you start to use this monitor. Movement of the endotracheal tube happens. We know it, but you'll see that it happens quite substantially. Being able to keep this tube in a safe position can really help you out. So if we think about what causes ETT movement, and do I really believe that the endotracheal tube is moving and that it moves at the tip when I don't have any movement at the lip? Well, there's a lot of different things that cause movement of the endotracheal tube. Everything from the baby moving or us repositioning the baby, different procedures we're doing with the baby, whether that's moving them for a chest x-ray or changing their linens, any of that. Even changing the baby's diaper as you lift their legs up will often move the tip of the tube downward. If your baby has hiccups, you're probably going to see that on the monitor as movement of the tip of the tube. Your baby may be tonguing the endotracheal tube and you're going to see movement there. Or if your tube holder gets loose or your tape becomes loose, then that's movement at the lip and at the tip. So keeping that endotracheal tube in what we're calling the safe zone, and in Module 2 we talked a lot about the safe zone, is going to help keep the baby and keep the baby safe, keep the tube in the right place. If you think about the times when movement becomes really dangerous, I think of kangaroo care, any repositioning, any procedures, all of that. If I know the tip of the tube is in the right place before I start those procedures, then I can move the baby, reposition the baby, place the baby in the mother's arms, and I know the whole time where the tip of the tube is, and I know if I've moved into an unsafe zone, I can quickly reposition the endotracheal tube or reposition the tubing, ventilator tubing, maybe taking a little pressure off the tube, anything like that. We talked about before that you can hear the breath sounds using the SonarMed airwave, and that can be also very powerful and a very powerful tool. To do that, you go into your main menu or your settings gear. You use your up and down arrows to go down to the monitor wave microphones, and you press enter. And when you do that, you'll see two microphones, A and B. Doesn't matter which one you listen to, they'll sound the same. When you're finished, hit your return arrow, take you back to monitoring. Again, we've talked a lot about suctioning and about secretion management, and it is really important that we suction the babies when they need it, but it's also just as vitally important that we're not suctioning if there is no need for it. I think that you're going to find there's such powerful information in this monitor. It's going to help you with your suctioning practices and will help us to keep the tube clean and keep the baby breathing easier. Let's talk a little bit about the alarms, what you see on the alarm screen. You can set alarms for movement obstruction and passageway size, or the size of the diameter of the trachea. And then you also can set your alarm volume. And when we set the alarms, it's really important that we're setting the alarms to make sure we know important information. Everybody deals with alarms all day long, and there's a lot of alarm fatigue in any intensive care unit. So carefully set your alarms for your baby so that you're getting the information alerted to you when you need it, but then you're not hearing alarms when you don't have, such as unsafe movement or an obstruction that's small enough as to not be concerning to you. With that, let's talk about, you come in, you walk up to the monitor and you see this. What do you think might be happening? I have a tube that has moved upward because my up arrow is illuminated, and it's moved up by 1.1 centimeters. Hasn't hit my alarm limit yet. My alarm's probably set at about 1.2 for a baby with a 3.0 tube. But it's moved significantly up, and now the baby is really at risk of hitting that upper limit, right? How about in this screen? What could be happening here? So first I see I have 2 millimeters of movement upward. That's not something that I'm concerned about, right? 2 millimeters of movement is not concerning. However, I also have a 47% occlusion, and it's down low in the trachea. You see, it's really at about the 4 centimeter mark in my trachea. Again, here's where we have a little bit of movement upward. 47% occlusion is getting to be a pretty large occlusion. And if it gets much bigger, you're going to see probably most babies will be saturating at about this time. All right, how about this one? What do we see here? So first thing I notice is telling me small passageway. Again, the diameter has changed. The number on the bottom in blue is 5.0 millimeters. And then the number above in red is 3.9 millimeters. So I've had a change in my diameter. It's set the alarm off. And it's showing me that I have a smaller passageway, a smaller trachea. And in reality, I've also had downward movement of 1.9 centimeters. So what do you think might be happening? Tip of the tube is moved down into the bronchus. So what happens if my sensor the cable becomes disconnected from the monitor? I'm going to get a message that says check my sensor connection. When I plug it back in, it's going to ask me if I need to perform a new calibration. Do I have a new patient? My answer is no, I don't have a new patient. This is the same patient. So I'm just going to check that X, the blue oval at the bottom, and say, no, I don't want to calibrate again. So how do we care for the airwave, and what kind of maintenance do we need? Certainly your user manual has all this information in there. You want to clean the airwave monitor between patients, and you use your germicide wipes that you have in the hospital for that. Clean the monitor, clean the cable. The cable is reusable. The sensors, however, are single patient use. You want to know your limits and contraindications. We're using it with, in the NICU, the 2.530 and 3.5 millimeter ID. We talked in Module 2 about it is not compatible with MRI. Great as a transport tool to the MRI unit, but not inside the MRI. As I already said, it is a single patient use sensor. Processing that sensor will damage it. Any kind of reprocessing will damage it, so you only want to use it on one patient. And the monitor itself is factory closed, as well as the sensor. Tampering with that in any way is going to avoid any kind of product warranty, but it also is going to possibly cause performance problems. So respect the airwave. Factory closures. And with this module, and again, if I were with you in person, I'd ask you if you have any questions. But since I'm not, if you have questions, please send them to us at www.sonarmed.com. Go to the Contact Us, fill out the information, send us your question, and we'll get right back with you. Thanks so much.